I'm Dr. David Good. I'm the president-elect of the World Federation of Neurorehab and co-chair of this webinar, along with Dr. Wayne Feng. I'd like to take a minute to thank the staff of Duke University for their technical support in helping to arrange this webinar. We really couldn't do it without them. We have a large number of attendees, more than 1,000 people registered, which I think reflects the concern about this virus around the world. I'm sure that all of you are aware about the rapid spread of this unique coronavirus. It's reached every corner of the world in the last 6 months. It's overwhelmed the health systems of several countries. As of yesterday, there were over 5,400,000 cases reported worldwide and almost 350,000 deaths. This is all in 6 months. Now, the primary target of the virus is the respiratory system, and this can progress to respiratory failure and mechanical ventilation. However, many other organ systems are involved, including the kidneys, the GI tract, the heart, and the neurologic systems. As neurorehabilitation professionals, we know that the COVID-19 has affected us, our patients, and our practice. Now, there are two very broad groups that I think are affected by the COVID-19, two large groups of patients. The first group are patients who have sustained physical or psychological impairment from the virus itself, from the actual infection. And these patients include patients who have profound deconditioning due to profound bed rest, or may have associated myopathy, neuropathy from a long intensive care stay. Guillain-Barré syndrome's been reported as well. And there may be confusion, delirium, psychosis, anxiety, depression, and post-traumatic stress syndrome. We're also aware of ischemic stroke associated with COVID-19 that we're going to hear about in one of our presentations. This can even occur in younger patients without the typical stroke risk factors. All these patients may require rehabilitation. Now, there's another large group of patients that could be affected by COVID-19. I like to call these our usual neurorehabilitation patients. And these include patients with stroke, brain injury, spinal cord injury that we'd be treating normally with rehabilitation. These patients are at risk of contracting the COVID-19 in the healthcare environment, and they may need special protection while they get rehabilitation. And finally, to protect our healthcare workers, including rehabilitation professionals who are at risk both of contracting and spreading the virus as they do their jobs. So the purpose of this webinar is to present the neurorehabilitation perspective on this pandemic, not only related to clinical care, but also research. Now, we have assembled a group of outstanding speakers, several who have had personal experience treating patients with COVID-19 and the complications. We've asked each speaker to limit their formal comments to 20 minutes. We can follow these with questions if we have some time afterwards that you can put on the, I think on the chat, looks like on the chat. Now, we also hope to have about 15 minutes at the end of the webinar for additional questions. So we hope you enjoy and benefit from this experience. We've been told that the webinar will eventually be available on the WFNR, World Federation of Neurorehab website. And although it won't be available immediately after this webinar, but it will be eventually available. The other thing is that this webinar has been approved for CME credit by the European Accreditation Council on CME. And I can't give you immediate information on that right now, but it should be available through the World Federation of Neurorehab website in the future, I hope. So at this point, I'm going to introduce my co-chair, Dr. Wayne Feng. He's a professor of neurology at Duke University. He's also the chief of the vascular neurology division and the medical director of the Duke Comprehensive Stroke Center. Prior to his time at Duke, he was on the faculty of the Medical University of South Carolina. His areas of special expertise are vascular neurology, biostatistics, epidemiology, neuroimaging and brain stimulation. He's a fellow of several professional societies. He's a member of the Presidium of the World Federation of Neurorehabilitation, and he's vice chair of the Neural Repair and Neurorehabilitation section of the American Academy of Neurology. He's a member of a number of editorial boards. He's had a number of peer-reviewed publications, and he's a well-funded investigator. He's going to give a couple additional comments, and then he's going to launch into his lecture today, which is the association of COVID-19 with stroke and other neurological conditions. Professor Feng.
Oh, thanks, David. Can you guys hear me okay? Can you guys hear me okay?
Yes.
Okay. Thanks, David, for your kind introduction. So I want to take an opportunity to welcome all the attendees from all over the world. We have over 1,200 people registered. At this moment, we have almost 600 people log in. People still try to log in. So thank you. Welcome to the symposium. I do want to let you know, please use a QA. Probably depends, it either show your up part of your screen or the low part of your screen. You can use a QA, or you can raise your hand if you have any question. And each of us will have 20 minutes and for the presentation. Then we have 5 minutes for the question. But in the end, we have another 15 minutes. So, and then I also want to take an opportunity I cannot advance my slides. Will, can you advance my slides? Okay. I also want to take an opportunity and let attendees know we do have World Congress for Neurorehabilitation, and it's this October in Lyon, France, and at this moment it's still on, but might be possibility we may have to switch to online form. So please keep it tuned. But at this moment, the conference is still on, and you can find a little more information to www.wcnr-congress.org to find the latest information about the World Congress. Next, I'm just going to start my talk. Is about the impact of COVID-19 to stroke and neurological disease. The first basic one I kind of give you a quick overview what kind of impact to COVID the COVID-19 to stroke and neurological disease, and before we can talk about the impact to neurorehabilitations. So this is my disclosures. So what is COVID-19? COVID-19 is basically a coronavirus disease 2019. It is a disease caused by severe acute respiratory syndrome coronavirus 2. It's mainly spread between people during close contact, and most often via small droplets produced by coughing, sneeze, and talking. The incubation time between 2 to 14 days. The lungs organ most affect, but it can affect the multi-organ systems in severe case. As David pointed, as right now, we have 5.5 million people and almost 350 people died from the disease. So it's really a global pandemic. The disease actually can go through the nose and could be quickly and infiltrates to the lung, goes to the broader system, or through the olfactory bulb or the vagus nerve, and it can affect the multi-system. And this slides probably show you a little bit better and how the coronavirus uses spike protein, uses ACE proteins, and they can quickly get into the system through the direct infection injury, go to broader system, and a neural pathway, and it can cause demyelinations and also cause breakdown of BBB, and also cause lymphadenopathy, and also cause inflammation. Or it could be directly causing immune injury. And through all these systems, and it actually can quickly and attack the multi-organ system, including neurological and a symptom. That's why we see, and which we'll talk a little bit more, it can cause acute cerebral vascular disease, cause encephalitis. It can simply just cause encephalopathy. Okay. This is the first and a publication from Wuhan where the disease first spread, and it presents basically over 200 cases. Basically, factor was a corona and its virus. At the same time, presents various neurological and manifestations. You can see, central 21 out of 4 patients have a central nervous symptom, and they can present with dizziness, headache, impaired consciousness. Stroke is relatively small. Only 3% of patients have a stroke. They can also present ataxia, can have a seizure, have a peripheral neurologic disease. Interesting, a lot of actually, and 10%, and actually continue increase. Right now, I think the latest data show 1/3 of patients actually can have impaired taste or smell. They can also present with pain. So this was really the first shot of the neurologic manifestation of a patient with COVID-19. So then in the United States, as you probably know, started Washington Post saying young and middle-aged people, no risk of stroke, suddenly they have a stroke. And then, and then all the media, including CNN, all broadcasting this about a young stroke, a middle-aged patient, they suffer a stroke, no risk, all due to COVID-19. In the end, this group from NYU and published data on the New England Journal of Medicine with 5 patients. They're all very young, ranging from 33 to 49. You can see it really doesn't have a lot of vascular disease risk factor. And they actually present all big, large vessel occlusion, such as patient 1 has internal carotid occlusion, patient 2 had a middle cerebral artery occlusion, patient 3 has posterior cerebral artery occlusion, patient 4, again, middle cerebral artery, 5 is all middle cerebral artery. Those all big vessel occlusion, and but the good part of all of them actually got treated with endovascular therapy. And further on, the New York healthcare system also published 63 patients and with stroke at the same time was COVID positive. They have other 2 groups. One is COVID negative. The other one is a historic control, means those stroke patients presents in the past. We can see those patients had a significant increase of D-dimer. D-dimer average was almost 4,000 compared to 526. The highest D-dimer is over 10,000 versus the COVID negative is really only 500. So you can see there's tremendous and inflammations going on. Same time, if we look at the etiology of the stroke, the big difference you can see, we don't really see any small vessel disease, okay, in this COVID positive. But we see a lot of patients have a cryptogenic, means we don't know what exactly etiology. Almost 2/3 of patients, we couldn't identify the etiology. And versus the COVID negative, only 1/3. And with history control, is only 1/4. But if we look at it, we would think of those embolic stroke, but we just cannot prove ourselves. Almost 50% of the COVID positives in a patient, basically, they have an embolus, but we just cannot prove where they're from. So clear there's maybe some coagulopathy going on, making those patients more likely to form embolus, causing stroke, but we just cannot prove ourselves where exactly the embolus came from. The other thing, the shocking difference is the mortality rates. 2/3 of patients with COVID-19 has stroke, they all die in the hospital. with COVID negative, only less than 10%. It's a huge difference. And look at historic control, it's only 6.3%. So this is really not a great combination. If you have a COVID-19, then suffer stroke, your outcome is not going to be too great. And this is the data published from Hong Kong, and saying that, they take a tremendous time for patient come to come to the ambulance and present to the hospitals. Look at the onset to the door. The time average for the COVID positive patient, and it takes 160 minutes to the ED versus the, and pre-COVID, it's only about 100 times. And this really causes delay how you're going to treat with and the TPA thrombolytic, and it directly have an impact on their outcomes. This is data published from France, a group of stroke neurologists. They're seeing those are all presents a big stroke, seeing overall there's a little bit decreased activity. You can see and a blue line shows all the COVID-19 patients. The yellow, light brown or yellow basically showing the stroke admission. You can see this slight decrease. What happened is really imaging to the groin area is got an increase from 126 minutes to 144 minutes, almost 20 minutes delay. I guess it's just because we have to put a protection on and have to alert the people and have to make sure we all do the protection, but at the same time cause some delay. You have to put a PPE. Look at the imaging to the groin delay, and it really, there's 30 minutes of delay. So there are some impact to those patients with actually COVID-19 and a stroke. And this also for the showing use of rapid imaging, we can see for some reason, and when United States and declare a stay-at-home order, and suddenly, people try to avoid a hospital, and the number of people stroke and get imaging was quite a bit of decrease, and over about a month period, then kind of slowly and then bounce back. With this, in the Canadian group, and also actually release and called a North American group and Canadian group actually put a protected code stroke. It means we have to protect our patient, have to protect the healthcare workers, and basically they highlight a very detailed and a process how to do a code stroke and put it in a protective fashion. Basically is if we know they're positive, if we're not quite sure and transfer from another facility, or patient cannot give a good history, you should put you protected device, and you should do protected code stroke. Okay, so strokes are not the only one was actually affected COVID-19. For patients have acute coronary syndrome, also see actually some decrease of admission in Italy. So really there are some an impact on the systematic care levels. So how people will be saying how in COVID-19 can cause a stroke? I think this diagram probably can show you, and a lot of COVID-19 patients, they have the risk factor. So they can, through their traditional pathway, they can cause stroke. But at the same time, COVID-19 can through immune response, hypercoagulability, coagulopathy, through direct invasion through the vascular system, through the ACE2, and they can actually also cause stroke, including hemorrhagic stroke. Although we don't see a lot of report on a hemorrhagic stroke, most report actually we find is a limit to ischemic stroke. I only so far see one case. So anyway, we just talk about it. And a stroke. What about the other neurological disease? This is data published from Italy showing, a weekend admission with COVID-19 was increased, and with COVID-19 was also kind of increased, then kind of decreased, and they see variety of patient was basically had a stroke or other neurological disease. The take-home message is COVID-19 patient admit admitted to hospital with neurological disease, including stroke, have significant high hospital mortality and an indirect delirium and high disabilities, and the patient don't have a COVID-19. So really, the data is consistent, reported from all over the world, showing this is a serious disease, have a really bad impact on the outcomes. As we know, the disease can also cause loss of sensory, loss of taste and smell. Look at this, COVID positive and lost the taste, 71%, and it was 17% lost the smell, and 68% and 16%, huge difference. This is the imaging show you actually the olfactory bulb is big swollen, and then during the disease, once patient getting better, once recover from the smell, and the edema is getting better. So really, once you hear patients suddenly lost the taste or smell, even they don't have a fever, cough, you should be a little bit vigilant and should test the COVID-19 for those patients. Interesting, once they recover with the taste and the smell and other neurological symptom also and recover. This is the slides I want to quickly show you, and a patient shows hemorrhagic necrotizing encephalopathy. Basically looks almost just kind of encephalitis with necrosis in the brain, and really affected by bilateral bilateral kind of thalamus kind of picture. And as a picture kind of shows you, this patient simply just presents kind of confusion, and the patient do have a stroke in the past, but now infected with COVID-19. Concern was a seizure, but but it didn't really catch it. But a patient presents encephalopathy. Kids, we think it was immuniform disease, but not really. Overall, still pretty small percentage of kids infected and affected with COVID-19. And a small group actually also exhibits a neurologic manifestations. This patient basically is only 6 weeks old, presents with a seizure. But I have to point out the family also had a family history of seizures. Okay, as we can see that we accumulate a lot of data and a lot of publication. We can see patient presents with coincident with the COVID-19 and the GBS, and presents a generalized myoclonus and an MS, and also hemorrhagic stroke. So really, as we accumulate more data and more publication, we can understand a little bit more what kind of profound impact from COVID-19 or SARS-CoV-2 and to neurological system. So here, due to time, I'm going to stop here. Quickly summarize, COVID-19 is a disease caused by severe acute respiratory syndrome, coronavirus 2. It can cause multi-organ system complications, including neurological and complications. There is a possible association between SARS-CoV-2 and a stroke as a neurological disease, but the mechanism is not clear. There's also negative impact of stroke care at a system of care level. Neurologists need to be vigilant about the various shorter-term and long-term neurological complications from this SARS-CoV-2. With this, I want to conclude. This is my laboratory, and I will be happy to answer some of the questions.
Okay, there are a couple questions here on the Q&A.
Okay.
Let's see here. Wayne, you may want to try to.
Okay.
Yeah.
So there's a question, what PPE do you use as a physiatrist or use while examining a patient with a COVID-19 and 19? What do you therapy use? So if the patient have a COVID-19, you really have to put it at 4. Let me just share the slides here. Can you guys see this? If this, you really need to put an N95, full sleeve, the gowns, eye protection, and the gloves. So you really need to protect yourself, okay? in view risk of infection, what do you advise bedside therapy? What do you bring them down to rehab units? How do you sanitize the rehab units? That's an excellent question. And better, if patient have a COVID-19 positive, you, as I said, you have to put a full-blown and a PPE. In terms of disinfection, I think there's a lot of talk about ultraviolet and to sanitize the rehab, but I can leave to vocal a little bit later. So that's all I have. David, is there other questions?
I don't think there's any other questions. Victoria, are there any other questions here on Q&A?
I'm seeing a couple. We have one from Raja, and he asks, because of high incidence of false negative results, should we treat all young patients presenting with stroke as COVID-19 induced?
That's an excellent question. If you can't get a good story and from the patient, you should presume they are COVID-19, and you should test for those. At least that's a policy at a Duke Hospital. We call it a person and an investigation called PUI. So you tested this, and before you have the test results, you have to assume this patient is positive. This is to protect yourself as well as protect the patient.
Perfect. We have a couple more, so let me know when we might need to move on, but I'm just gonna
I'll do one more question.
Okay. Let's go with Nirmal's question. How do you treat acute stroke patients that come in 3 hours until the test reports come? What about intra-arterial intervention?
Well, you treat it exactly the same way. Within the 4.5 hours, you treat it with TPA. Beyond the 4.5 hours, you use imaging to identify patient. If you have a large vessel occlusion, and if you have a salvageable tissue, you should proceed with lumpectomy. The bigger issue is we all have to do the protective fashion. So the process is a little bit delayed, and we should try our best not to delay and try our best to save those patients. But a treatment is exactly the same. The only issue that we have to do the protective fashion that may slow the process a little bit. With this, I think I have to stop here. We have to leave the second speaker. Walker, I'm gonna open your slides. And Will, can you open the slides on your end, or I can do my end?
I can't do it. I don't have his slides on, so you're.
I email you, but I'll just do my end.
Right.
Yeah, I'll open on my end. Hold on. And
David,
you can go ahead and introduce. Mm-hmm.
Okay. While you're doing that, let me introduce Professor Volker Homburg. He's the head of neurology and medical director of SRH, the Gesundheitszentrum at Bad Wimpfen, Germany. Professor Homburg has a distinguished clinical and research career. He's been president of the German Society for Neurological Rehabilitation, and he's been the Secretary General of the World Federation for Neurorehabilitation for 17 years. He also was the Secretary General of the European Federation of Neurorehabilitation for 9 years. He's currently the Vice President of that organization. He has many research interests. He has a distinguished research career. He's got over 200 original articles to his credit. He's been a major organizer for many international congresses and has been very involved in the 12th World Congress on Neurorehabilitation scheduled in October in Lyon, France. The topic today is managing COVID-19 patients in an inpatient neurorehabilitation unit. And I understand he's had a lot of personal experience in his institution with patients with COVID-19. I'm sure he'll share that with us. Professor Homburg.
Okay, David, thank you very much for the kind introduction. Good morning, good afternoon, wherever you are around the world. What I want to do within the next couple of minutes is just share some of our experiences in dealing with patients with COVID-19 disease, but also with patients who have been infected with COVID-19 disease and who eventually may spread that to an inpatient rehabilitation place. I'm running a 400-bed inpatient rehabilitation place, probably one of the biggest in Germany. And the idea is to give you some hints what you can do to go on with rehabilitation, but on a safe way in order to avoid spread of the virus when it reaches into your body. Wayne, can you advance the slides for me?
Yes.
Good.
You just say next slides, I'll do it. Mhm.
Okay, so the question is, what needs do we have, what risks do we have, what perspectives do we have in terms of ongoing inpatient rehabilitation dealing with the coronavirus pandemic? Next. You know that everyone in the world knows that we haven't experienced such a pandemic for many, many years. We are dealing with a new virus. We don't know very much about it. We don't have a cure for it. We don't have a vaccination for it. So, of course, governmental means have to be taken to contain the virus, to avoid virus spreads. That is done in very different ways around the world. And sometimes you have the idea that it's good leadership. Sometimes there's simple ignorance and even denial that the virus exists. I don't want to go further comment on this. Nevertheless, next slide. Okay, what we have to realize really is that we don't know very much. You know, Socrates, the famous Greek philosopher, came up with this statement, I know, Oidogedos, I know that I don't know. And in actual fact, we are still very much in a position that we don't know very much about. We don't know very much about its epidemiological features, the speed of spread, other super spreaders, what are really pertinent containment strategies. We're just playing around with that in various parts of the world. Wayne already mentioned that we are dealing with a very diverse clinical phenomenology. And day by day, in actual fact, we learn more about the clinical phenomenology of the COV-2 problems. It's not just a lung disease. The question is, are there long-lasting sequelae in patients who are survivors or even are claimed to be sanitized from the virus? We don't know very much about the immunology. The immunological tests now become available more and more. We don't know if you have that you survive the disease, how long immunity lasts, and how long you will not be able to spread the virus again. We don't know very much about it. Next, Wayne. In some sense, COVID resembles syphilis about 100 years ago in the sense that sort of a monkey of diseases. It mimics a lot of problems. And as Wayne already mentioned, it does not just affect the lung. It's the central peripherous nervous system which is hit. It's certainly the heart which is hit, the kidney. The hematological system is hit, and possibly other systems as well. Next slide. Yeah, we know that probably the virus is nesting into different organs and different tissues by the ACE2 receptor. We don't know yet the influence on ACE2 blockers, for instance, on being beneficial or being harmful for spreading the virus. We know it goes into the central nervous system, definitely goes into the lung, it goes into heart and other organs. Next slide, please. Okay, this is just a paper published from the group from Wuhan in China, where possibly the virus has originated with in the beginning, and they looked at this cohort of 240 patients, and it's just about neurological signs and symptoms. 43 of them were presented with symptoms, unspecific symptoms of vertigo, headache. 26 had taste and smell abnormalities, 6 experienced stroke, and in 23 there were neuromuscular problems as well. Next slide. This is a recent article on the frequency of smell and taste problems, and you see this in this cohort of 470 mild to moderately affected COVID-19 patients. Over 80% of the patients reported olfactory and gustatory dysfunction. Next slide. Okay, so there the plethora are reporting neurological manifestation. Wayne alluded to that already in more detail. Just to keep in mind, it's a very, very broad range of neurological signs and symptoms which may occur, up to complete stroke probably related to the virus itself. Next slide. Okay, this is a recent study from France, and they looked at 64 consecutive patients. And as you can see, the neurologic findings were reported early in 14%, and later on there was an increasing number of neurological signs and symptoms in these otherwise not neurologically affected COVID-19 patients. Okay, let's go further, and now I come to more to the core of what I want to say. Next slide. Of course, also, this is just one example there. Almost every week, papers are appearing showing primary and neurological manifestation, also neuroimaging, with COVID-19 problems. Next slide. Okay, nevertheless, COVID-19 is certainly not the only disease in the world. And we have to go on with rehabilitation of patients who had stroke, traumatic brain injuries, spinal cord injuries, and the whole spectrum of disorders which need neurological rehabilitation. And the question is how we can go on to provide rehabilitation for severely affected neurological patients in a secure way in inpatient department. The question is how that can be done safely without running the risk of spreading the virus within a rehab environment. And we had a fairly painful experience with that. Next slide. Can I have the next? Yeah. In our 400-bed inpatient rehabilitation department, in early March, we started with careful patient selection, so we did not take in any patients who had a possible history, so a suspect of COVID-19 problems. We have been travelers to hotspots around Europe and so forth. We did very vigorous symptomatic control on all of these patients. And whenever a patient was found to be possibly symptomatic for a COVID-19 related classical problem as some fever, coughing, or whatever, they were isolated in isolated rooms. Staff was wearing a surgical mask or FFP2 mask in rooms of symptomatic patients. And by mid-March, we closed the hospital completely for visits. Next slide. And in early April, we had the first staff members who were tested positive in the community, so they were probably infected outside. So we banned them from coming into the hospital, and nevertheless, we found the first positive tests also in some of our patients. Those patients remained isolated with very rigid symptom control, and if necessary, of course, they were transferred to the ICU. By mid-April, we decided to test all remaining and not yet tested inpatients, a couple of hundred, and the entire staff. And the result was striking. Next slide, please. So we found a total of 85 patients tested positive, and also about 50% of the staff, with a total number of roughly 108. 60 to 70% of these patients tested positive for the COVID virus were free of any suspect, classical, clinical signs and symptoms. We are just running the rough analysis for all these patients in detail. They were cohorted on special wards. The majority did pretty well. And after 2 weeks or so, they were considered to be cured and left the hospital or went to other wards back. At that time, by mid-April, we put the entire hospital under quarantine and did no one get out and in unless under very rigid constraints. Next. So just to give you a short resume of what our experience was from this outbreak of SARS-CoV-2 virus spread. Definitely, it is not sufficient to just monitor clinical symptoms when you want to be on the safe side. Many patients and staff have the virus and may spread it while being completely asymptomatic, don't have anything. So, of course, that means the virus is extremely contagious. And to prevent You need absolutely repeated testing. Repeated testing is absolutely mandatory if you want to run such a place in a proper and safe way. Next slide, please. So, could I have the next slide, please?
We have a little issue. Hold on.
Well,
Cannot.
okay, so the question was what sort of safety features we can do and we developed.
Yeah, it's good now.
Okay, so we developed sort of a safety concept. Of course, you need rigid control of the general hygiene standards, hand washing, all of what you are familiar with. All staff now is using FFP2 or KN95 masks. All patients are using surgical masks on the other side. Well, of course, we have to think about how to marshal therapies in these patients. And the idea is really we want to reduce personal one-to-one contacts with therapists and nurses to a minimum. This minimum should not exceed contact times of 10 minutes or longer. If you need longer times, you have to fractionate that in different parts and avoid more than 10 minutes direct contact time, even although you use the mask and all the personal protection system. We put an emphasis on hands-off, remote coaching approaches instead of hands-on treatments whenever it's possible. And of course, we ask everyone to keep distances of at least 1.5 meters between patient, staff, and so forth. Next. Well, it's essential, of course, is the assessment of patients' infectious status. We usually get patients in 8 or 10 days after they leave the stroke unit or they leave their surgical departments, or sometimes we take patients in from the unit. And so to create a safe environment, we subdivided the entire hospital areas in 3 completely different sections. There is a COVID-19 section in which only COVID-19 proven patients are treated with neurological problems with COVID-19 after ICU care, critical illness, neuromyopathy, whatever. Then, for patients coming in new from, let's say, other hospitals, acute hospitals, or from the community, we have clearing wards for patients with undetermined infectious status. So what we do is we test them when they come in. Immediately, we have rapid testing systems now giving us the first result after about 60 to 70 minutes, which we can do ourselves. These are pretty specific PCR-based tests. And depending on their infectious history, that of course is dependent, have to be tested before, what the lengths of stay in the hospital. Did they test the patient there? Did they not? We put the patient under room isolation, do all the therapies in the room, or just allow the patient into bigger therapy areas, accompanied by a therapist or a nurse with complete protection. And we have to do that, and some of them up to 14 days, just to allow for the maximum reported time. If you just have a patient coming in with a negative testing, that doesn't mean very much. They can be positive a couple of days later, so you have to really isolate them for a while until you are certain that you can put them in a non-COVID part of the hospital, in which, of course, more liberal circumstances are possible for the patient. They can leave the rooms and they have the right area where they can be treated and can walk around and enjoy a fairly normal situation. Next slide. Yeah, on the clearing and non-COVID sections, patients have to be regularly checked, of course, for COVID suspect symptoms. We do that at least twice daily. And those who are at risk, older age, who have primary preceding immunosuppression or any other of the risk factors to develop COVID as a disease, they are checked into our intervals. The staff is also regularly checked for COVID suspect symptoms daily twice. And whenever symptoms occur, we retest them. We avoid any crossing between these sections. So each of the sections has a different team working there. And patients from one or the other section never cross their ways. Staff with risk factors for COVID-19 age, presence of lung problems, immunosuppression, or others, work only in the non-COVID sections in order to decrease their risk to develop COVID-19 problems themselves. Next slide. Yeah, that is basically it. It just give you some hints what can be done. I think the bottom line of all of this is we are dealing with a complex disorder, multi-organ disorder, with a very diversified clinical phenomenology. It's not just coughing, it's not just developing fever. There may be many other features being suspect, and without testing, there is no way really to do that in a safe way in a bigger inpatient hospital. Wayne already mentioned we will have, or we're planning to have, the next World Congress in Neurorehabilitation in October and beyond. It's not definitely decided yet if we do it in an on-site basis. That will be very difficult with the present situation. I think with the pandemic situation also in Europe, we may eventually switch to a digital form, but we'll let you know in time. Thank you very much so far for your attention.
Thank you very much, Professor Homburg. I think we have time for maybe 4 or 5 questions before we move on.
Perfect. I'll go ahead and read a couple if that works for you guys.
That's great, Victoria. Thank you.
All right. Yeah. How is acute management of GBS different in a COVID patient?
Well, basically, let's say the treatment of all neurological problems are basically the same as in the non-COVID. The only thing you have to take care of are two aspects. One is that in addition, there may be extra COVID problems occurring. And the second part, of course, is that you have to safeguard that you're not spreading the virus from the patient, for instance, to the staff. So that means that, for instance, you have a Guillain-Barré patient or you have a stroke patient, you will probably treat them very much the same way originally as you would do in a non-COVID. But you have to be more careful. The staff has to reduce the on-time, the one-to-one on-time, fractionate it into 10 minutes chunks. So that are changes in terms of organizing the therapy. But the content of the therapy, what you do is more or less.
Perfect. Do we know whether the olfactory impairment in these patients reflect peripheral damage or central damage in olfactory pathways?
Well, there are data now that possibly the virus spreads through the lamina tuberosa into the olfactory bulb and may spread further to the entorhinal portion and the so it's probably a migration of the virus throughout the olfactory system.
For acute rehabilitation, the therapist provided less than or equal to 10 minutes of rehabilitation. Question. That was a question mark.
Well, it's just the contact time of 10 minutes. And if you need more, then you fractionate that and you make a break, and then you avoid the therapist to be longer than 10 minutes, unless they are wearing complete overall protection. That of course, is the one on the COVID-19 wards. It's much easier because they are wearing their complete protection all day over. That's much easier to manage.
Okay. Were they the patients treated in their rooms, or did you have a COVID-19 gym space?
No, in the clearing wards, we usually isolate the patient in a bigger single room, and then we allow them with full protection to leave the room in the presence of a therapist, go into a bigger therapy area. In this therapy area, we avoid any crossing with other patients, and these are pretty big rooms, so we have at least 20 square meters per patient when they are treated there. And of course, in this, where we don't know the infection status of the patient, we keep them under full protection.
Okay. What are the main assessment and scales that can be used to I'm assuming, assess COVID-19 patients who are transferred for neurological rehabilitation?
Well, it's difficult to say because as I mentioned, the COVID-19 related clinical spectrum is extremely broad. So the most important point is that you need proper testing. And if you know the patient is positive, then of course that changes your management. The bigger problem are those patients in whom you do not really know the infectious status. Because if you test someone who's coming into the hospital and you don't know very much about the preceding history, and there's no preceding testing available, you don't know anything. You have a negative test, so you put him on a clearing ward. And depending on the information you get in, you will retest them after 7 days and we'll retest them after 14 days. So we allow the max for 14 days. And some of these patients have to stay for 14 days on these contained, isolated.
Maybe one more question, Victoria?
Let's see. We're getting a lot. I'm just going to ask really quickly of our attendees, if when you submit in the Q&A, you don't need to submit twice. We will eventually get to your questions, even if it's not right after the presentations. We are going to answer questions after all of the presentations have completed. But really quickly, did limiting the therapy contact impact the outcomes on the patients? Since that's
well, we don't know. I think we try to keep, let's say, the total therapy frequency as high up as we can do. That, of course, imposes quite a burden to the therapist. It's much more complicated in these patients with unclear infectious status. It's easier in the COVID patient where you really know that there's one cohort. But nevertheless, we try. If there is a patient, let's say, has a stroke or he had a whatever neurological disorder, and later on is positively tested for COVID, then of course you do not know was that the cause of the stroke, unless the stroke was 3 weeks before, and then it's much more likely that it's a stroke not related to COVID, and that is a stroke patient who, in addition, has a COVID.
Okay.
Katerina, can you just bring your slides on your end?
Yes.
Yeah. While David introduce you.
Thank you, Professor Holmberg. We appreciate it very much.
A pleasure.
All right. So we'll introduce our next speaker while her slides are coming up. This is Professor Dr. Caterina Pestrini from the Istituto Marguri in Genoa, Italy, where she's the organizational and scientific director. Since March 2020, she's been the director of neurorehabilitation at all 14 institutes of the ICS Marguri company. In addition to her administrative responsibilities, she's a clinician with special interests in traumatic brain injury, spinal cord injury, and coma. She's also an active clinical investigator. She's been president. Let's see, we lost it here. Slides are coming up, I guess. She's been president of the Italian Neurorehabilitation Society, and she's an elected member of the Presidium for the WFNR. She's currently Secretary General of the European Federation of Neurorehabilitation. Dr. Pestrini has been an invited speaker at many international congresses, and her talk today is the Italian experience and criteria for the resumption of rehabilitation activity. Caterina?
Thank you so much for your kind presentation. Thank you so much to all the attenders for their participation to this meeting on COVID impact on neurorehabilitation setting. We describe the resumption of rehabilitation activity starting from Italian experience. As you know from previous slide, we understand that COVID pandemic present a unique challenge and opportunity for the field of neurorehabilitation because we can have many neurological and neuromuscular conditions and sequelae from the infection itself, but also overall the debility, acute hospital and intensive care unit stay, and the need for invasive device can determine physical, cognitive, and functional deficit that require both acute and long-term intervention and care. The added psychological stressor and the marked reduction in preventative health care brought on the pandemic increase the need of neurorehabilitation intervention. Moreover, individuals with other neurological disability who are at other risk for functional and medical decline are likely to be receiving less than optimal preventative and restorative service, and rehabilitation care have been modified to meet their need. Nowadays, we know that the global number around the world are approximately 5 million of cases. These are official number. In Italy, we experience the COVID pandemic at the end of January, and the spreading of virus involved in particular north region of the countries where we have the more industrial town. And nowadays we are in a healing period. In the month of April, May, we have healing period. The lockdown is finished, but the restriction measure for the containment of a virus are very strictly. We had a very important number of cases, important number of deaths, but also important number of recovered patients. Given the difficulty to offer appropriate care for these patients, not only in acute setting, but also in rehabilitation setting, we push us to rethink our care system, not only in acute setting, but also in rehabilitation setting. I'm working in rehabilitation setting, Department of Neurorehabilitation activity, and we divided our pathway of care in different settings. One setting for COVID patients without need of intensive care unit support. For these patients, specific staff of addressed professional have been dedicated, and for these patients the professional have been equipped with appropriate device. Minimum staff as required by the Ministry of Health. Other settings have been dedicated to patients who never experienced the infection, patients with other neurological disability, because of stroke, brain injury, or other neurodegenerative disease. For these patients, given the particularity of the work of rehabilitation, where direct or prolonged contact between a patient and operator is expected, as well the duration of hospitalization, it has represented for us a very challenging task. Other settings have been dedicated for patients who passed the infection with the negativization of the swabs, requiring rehabilitation treatment. For these patients who could go home because neurological need in neurorehabilitation specific setting in hospital, we planned a specific system of care. In neurorehabilitation project, in our neurorehabilitation project, we consider the assumption for the effectiveness of rehabilitation. At first, the importance to start early with the rehabilitation. In acute setting, rehabilitation is very important because we have to improve respiratory function. As you know, respiratory function is the more impaired situation, and this is important to take in charge patients as soon as possible. Other aspect that we have considered to improve our short-term objective in our rehabilitation project was to take in consideration the involvement of other organ and tissue. As you understood from a previous lecture, that the involvement of different organ and tissue can be caused by the virus itself. We have also to consider that it has been important to prevent secondary damage due to long bed stay. And in these cases, we start as soon as possible with passive and active mobilization of upper and lower limb to avoid some problems such as rigidity of a muscle and joint, deep vein thrombosis, or skin pressure shock. We considered the importance to assess nutritional status to support these patients with supplemental nutrition in case, and to offer psychological support when behavioral problems such as disorientation, confusion, or delirium were present. Following the improvement of condition of patients, we planned long-term objective in our rehabilitation project. Take in mind that the recovery of autonomy of patients is the main aim of neurorehabilitation. So specific exercise to improve muscle strength and endurance, to improve static and dynamic balance, to improve the ability of cognitive function and communication, to improve the ability in activity daily living, have been addressed to specific impairment with the technical solution following the professional knowledge. We know, and the previous speaker yet outlined that the containment of the virus limit and reduce drastically the spreading of disease. For rehabilitation, this forced us to find alternative strategies for the recovery of patients, but also to enhance the frequency and intensity of rehabilitation protocol in condition of maximum adherence and motivation of patients with good compliance of patients. Telerehabilitation is well-known strategies that can help us in situation of COVID spreading, but also in many other conditions where we need to enhance the the recovery of patients. In this slide, you can see the operating modality of telerehab. There are essential two modalities. Online modality, that is when patients trained the exercise autonomously at home in remote way, and the control of a professional from hospital is direct on patients. Offline is another modality. The list of exercise is delivered to patients. Patient execute this exercise autonomously, and the follow-up can be made in hospital. This is a suggested suitable alternative to our treatment when we restart with outpatient service in our hospital, to have a controlled restart in total security. Other solution for rehabilitation in remote way are represented by smart solution. Smart solution guarantee a continuous and coherent relationship from in-hospital setting to domestic environment in a supervised way. This solution allow personalized consultation and treatment via telephone or live internet connection or via pre-recorded session. In some countries, well-developed, secure virtual care platform already exist. In other, media such as Zoom, Skype, FaceTime, and other may be suitable alternative. However, it is to take in mind that we can have some limitation for this technological support, technical malfunctioning, or not ready availability of equipment. And for this, when we adapt smart solution, we have to consider general or specific requirement. General requirement can be to set a series of physical exercise, muscle, joint, appropriate for a patient clinical condition, and to change this protocol according to degree of patient clinical recovery. Other aspect very important is that the exercise must be shown clearly with a brief written explanation or video, and this can avoid to cause problems even for patients unfamiliar with technological device. Specific requirement can be to identify the type of exercise that the patient can carry out before and the supervisor can control in a second time, to record some physical parameters that have to not be invasive, and in case to provide warning signal launched automatically by the device if parameter threshold are reached. This considered system permits to link the offer of neurorehabilitation treatment with teleconsultation. In this slide, you can see the new strategies. This is a new smart solution. Patients at home can follow his exercise autonomously on the television. Television is a sort of mirror, and supervisor can control online the exercise. This box contains an internet card that ensures the connection with the television and external cloud, where are stored all the data of patients. Patient can perform with the system a physical exercise or with air mouse, cognitive exercise. We can also monitor some vital parameters such as cardiac frequency or breathing frequency by pulse oximeter placed on the finger of the hand of patients. Then, in summary, COVID epidemic, COVID pandemic has been experience for us that open new door for neurorehabilitation treatment. The possibility to connect treatment in hospital treatment with treatment at home can be helpful in the future when we want not only consider the importance of neurorehabilitation treatment in specific situation like this pandemic, but also in a specific situation that depend on individual need or context, environmental condition. We have to take in mind that rehabilitation is a continuum of care that follow patients from acute setting to discharge from hospital and at home, where also to address appropriately the caregiver and the parents can be helpful to support the patients. We have also to consider different solutions that can be developed also for patients who in a specific situation because neurological disability due to different condition can experience a feeling of isolation. We have to offer to these patients appropriate solution for their treatment. So we can think to rebuild our neurorehabilitation activity. This is a unique challenge for offering new possibility of neurorehabilitation treatment, and we can discuss on this within World Federation of Neurorehabilitation when we want to offer greater quality, adherence, and effectiveness of our treatment for all patients who need. Thank you so much for your kind attention.
Thank you very, very much for that excellent lecture, Dr. Pestorini. We appreciate that.
So David, we're gonna do a poll. So I'm gonna make an announcement on the poll. We forgot doing the poll.
Right.
So I'm launching a poll, and everybody can see this. You can go ahead and just vote. It will show up your screen, and the panelists can vote as well. And it shows up your screen. So please vote. Yeah. And at the same time, we're gonna answer some of the questions. Victoria, do you have some questions?
All right, we've got a lot of questions. They're coming in pretty steadily. So let's start off with, let's go to the bottom. How telemedicine is possible for complex and severely disabled patients and patients with DOC?
We can this is an important question because we can offer our treatment, rehabilitation treatment for all patients who need rehabilitation. In our hospital, we work with patients who come from acute setting. So we decided to offer neurorehabilitation to COVID patients to guarantee, to ensure full responses to their need. And we hospitalize patients with the stroke, with brain injury, and to ensure a good and a continuity in taking charge. When these patients become negative because two negative swabs, but nowadays we link also the negative swabs with the immunological dosage because we know very a little number of data about the spreading of virus. We try to insert these patients in orange zone, that is for zone for patients who pass the infection but need supplemental surveillance.
Okay. Can virtual reality rehabilitation be used to rehabilitate patients who cannot come for rehabilitation regularly?
Yes, they receive rehabilitation in acute setting when the physiological condition of patients can support to take in charge of these patients. The taking charge of rehabilitation in acute setting dependent on the clinical condition of patients. If patients need to support rehabilitation, we dedicated minimum staff. Minimum staff was included professional such as a medical doctor, physiotherapist, psychologist. Physiotherapist addressed his intervention in particular on the improvement of respiratory function, on the training of static and dynamic balance, and patients in this condition can support more and more a long time of rehabilitation.
Okay, I think we have time for just one more. What kind of training did you offer to your rehab team to cope or address COVID symptoms?
This is the training in COVID included different situation, but we have to take in mind that the recovery of patients is different in each individual. So the main problem that we face now is to achieve the maximum degree of autonomy. Now we controlled the infection. The real problem now is that many patients can exit from red zone, controlled zone for COVID patients, because the negativization of swabs is very slow.
Okay. Can you hear me, Victoria?
Yes, I can hear you. Did you want to do
Yeah.
one more, or are we ready to move on?
I think we're ready to move on. I've been cut off from the video, though. I'm not sure why. But let me go ahead and introduce our next speaker. I'd like to introduce Dr. Thomas Platz from the University of Greifswald in Germany. He's active in clinical neurorehabilitation, and he is the head of the Department of Neurorehabilitation at his institution. He's also the medical director of research at the On Institute at the University of Greifswald, and he's a member of various national and international neurological and neurorehabilitation societies. He's currently the president of the German Neurorehabilitation Society, and he's head of the educational committee of the World Federation for Neurorehab. One of his most recent projects is serving as the lead editor of a major multidisciplinary frontiers project entitled COVID-19, a Neurorehabilitation Perspective. Perhaps he'll tell you a little bit about that. His topic today is clinical research questions during COVID-19 pandemic, the neurorehabilitation perspective. Dr. Platz.
Thank you very much, David, for this very
Hey,
nice.
Thomas, hold on one second.
You
Sorry.
want to go to the poll first?
Yeah. Can you guys see the poll?
No.
Oh,
Well, maybe I have to stop.
you have to.
my
You have to
sharing.
stop. Yes.
Yep.
Okay.
All right, guys. Actually, the attendees can see the poll. As the panelists, you might have a little bit of a different view, but they should have just gotten a pop-up that says that host is
Okay.
sharing poll results.
Okay. I'm just announced the. Oh, let me see if I can share. Actually, cannot share the poll, but anyway, I want to announce the poll. So based on the 458 attendee do the poll, we have 30% from Asia, 20% from Europe, 9% from North America, 31% from South America, and 4% from Africa, 3% from Oceania, and 4% classified from other country. The age group, 10% from less than 30 years old, and 69% is range from 30 to 49 years old, 21% is 50 to 69 years old, and 2% older than 70 years old. And look at the attendees professional, we have 41% and are physical medicine and rehabilitation, and 11% are neurologists, 5% are physician other than PMR and a neurologist, 35% are PT or occupational therapist, 7% are speech language pathologist, 9% are researcher, and 4% are students in training. Have you taken care of COVID-19 patient in the last 6 months? 26% and an attendee had an experience of taking care of COVID-19, and 75% has not experienced. With this, I will and pass on to Thomas.
Thank you very much. I mean, that's great. I mean, that's a marvelous audience, isn't it? It's really international, right? It's multi-professional, perfect. So I think that's just the way I'd like to look at it, considering my talk. I mean, my talk is about a task that we in common have. We have a very new disease, COVID-19, and let's focus on neuro COVID-19, as we have done during the last 1.5 hours. And there's very little we actually know in terms of evidence for neurorehabilitation, and still we would like to base our clinical care on evidence. So this is basically the key message of my talk. This is a common task for all of us around the world. But my talk will be about the research perspective for neurorehabilitation in general, and that makes it pretty quickly clear that there is a broad range of research necessities in this pandemic. I will come back to some of the data that had already been presented, but maybe from a slightly different angle, so that is there already knowledge that we can use for our clinical practice, and how are we going to move forward in terms of research? And research in this kind of pandemic situation has kind of its own regulations and rules. And we as WFNR want to promote some of high quality fast track review research management, as I will point out a little bit later. So the first point is neurorehabilitation is very complex. Now, if we go here in the middle of the slide, this is from a very recent publication. Of course, there are different health conditions that we have to address, and COVID-19 is just one, and it's not just one. Neuro-COVID is a multitude of conditions already. And then translating from that brain dysfunction or nervous system dysfunction, and this is the type of evidence we have maybe, we know relatively little about the body dysfunctions that we see, about the disabilities that come out of it. and about the evolution of that across the time span from the very acute situation to the home care situation in the long run. Of course, we have different disciplines and they have the different approach, different research questions, and we might need to address some of the aspects of intervention. We have kind of indirect evidence that we now use. And so, by and large, it's learning from basic science. Maybe we can translate from there to the clinical practice. We might need intervention trials. If data is accumulating, we will see maybe systematic reviews related to it. And of course, now we are in the beginning of a pandemic, and the recommendations that are made are mainly based on clinical reasoning, but it would be very good if we had more evidence really to support our clinical decision making. So the specific research questions could be, in what way does COVID-19 affect the nervous system? And I think we do have some ideas here already, as had been pointed out by the previous speakers, and I will come back to that in a minute. But then how does that relate to body dysfunctions? How does that relate to disability? And what is the evolution of those more long-term sequelae of the health condition neuro-COVID-19 over time? As we have heard, there is a huge demand on really knowing how do we protect people? How do we protect staff? How do we protect patients who are SARS-CoV-2 negative? How do we protect visitors? And this is a mutual scenario, visitors to patients, patients to visitors and staff and the like. And of course, there's then, as Katharina pointed out, this telemedicine aspect. How do we administer care, maybe remotely in some instances? And do we have knowledge about how to treat patients on a rehabilitative perspective? Or do we have a need for more and more specific clinical intervention trials? I mentioned the other aspects. So let me just give you a few examples along these lines. Now, can we learn from basic science? Yes, here an example from Lee that says, okay, these coronaviruses, by and large, share some characteristics. And one of it is that they have a neuro-invasive propensity. So it might very well be that SARS-CoV-2, like other coronaviruses, is coming into the brain. And if that, for example, if the virus could affect the brainstem, and this is what the authors here reckon, it might well be that brainstem dysfunction is one reason why respiratory failure is prolonged and weaning is prolonged in these COVID-19 patients. So it's a hypothesis, but for us in neurorehabilitation, maybe taking care, and in Germany people do, in terms of prolonged weaning from mechanical ventilation, COVID-19 positive patients, we might have to consider the possibility that there is CNS problems being associated with the respiratory failure as well. You have heard here this about this series from Strasbourg that people with COVID-19 do have a variety of central nervous system related symptoms. There is agitation, confusion, what these authors here call cortical spinal tract signs. If you look into the paper, you would see it's increased tendon reflexes. It's kind of a higher startle response. So it almost looks like an increased excitability status of the brain. And associated are these leukoencephalic changes in the brain. And some do have strokes, as we have heard. So you see this? there's a variety of problems, and when Dr. Feng had already shown this more recent cohort study that shows, okay, stroke, fortunately enough, is not that frequent. It's only in this population in the New York Health Centers had only been 0.9% of people admitted with COVID-19. So it's a relatively low number, lower than the roughly 3% that had been reported from China. But the picture is different. Those that had been affected had more severe strokes, and the in-hospital mortality had been higher. More younger people, more men, and these, in terms of the etiology, a high percentage, 65% cryptogenic. So a different type of stroke, maybe related to an acquired hypercoagulability. For us in rehabilitation, we need to consider that there will be COVID-19 patients that will suffer from stroke. It will be most likely more severe strokes on average, and we will have to take care of them. And in a different way here, now this was a sample of people who COVID-19 affected who had been on ventilation because they had respiratory failure for a prolonged time. I think it was on average like 26 days. And then they had altered mental status that could not be explained just by drugs. So altered mental state in this scenario meant that they did not respond appropriately to noxious stimuli in terms of facial grimacing or movements of the limb. And when they had been looked at in the MRI, there are two kind of pattern that could be seen. One is patchy hyperintensity signals in the brain, mostly supratentorial white matter lesions and micro bleedings, micro hemorrhages. So showing that there is a different type of brain organ pathology leukoencephalic. And we might have to be aware of that, especially with the most severely affected who need the ICU for a longer time on the ventilator. And here, Dr. Feng has alluded to that too. This is another way the brain might react to COVID-19, generalized myoclonus, being reported in Spain. Now, these three people had, and it was stimulus sensitive, generalized myoclonus. It's predominantly affecting the brain, the face, and the proximal limbs. So it had a pattern that looked as if it was brainstem pathology related. No EEG signs of epileptic myoclonus. So maybe again, another sign that there is some very specific connotation between the virus and the brain and its system. And regarding this Guillain-Barré syndrome issue, again here, this is a series from northern Italy, and among estimated 1,000 to 1,200 patients being admitted for COVID-19, there had only been 5 patients wherein Guillain-Barré syndrome had been diagnosed. But here the important issue is they had been treated. There was this question, how had they been treated? It was treated in a similar way as other GBS patients would have been treated. But the important issue here is that this presentation of severe leg paresis or tetraparesis or facial diplegia occurred relatively early during the disease, maybe after 5 to 10 days of symptom onset. And so I think the important issue is here really to pick up that this scenario is distinct from what most likely can be seen in COVID-19 patients needing the ICU, the critical illness neuropathy and myopathy, which might, however, develop at a later, somewhat later stage at least. So I think the important thing here is really to pick it up and distinguish it, because in terms of electrophysiology must not be distinct, but in terms of the cause of the disease and certainly the treatment that follows. Now, these had been clinical epidemiology studies, and do we have systematic reviews? I'll show you one example of a systematic review from the US, and they looked into the incidence of the association of COVID-19 and neurological conditions, might have been pre-existing or secondary. And I think that was one of the questions in our chat room that asked, how frequent are these secondary neurological conditions? And we would have to say, I mean, they are different conditions, so there could not be a single number, and certainly our estimates on that are not precise yet. But what you see here is that the secondary neurological complications had been reported from something like 6% to 36%. So it's a relatively high proportion of people being affected by COVID-19 could be coined neuro-COVID-19. They do have secondary neurological complications, and that has the implications that there will be, if it is not already there, but there will be an increasing need for neurorehabilitation services to prevent long-term neurodisabilities in that patient population. Now, are there examples from randomized controlled trials? Well, none from the neurorehabilitation community really, but a very nice example here. I think it's the first big positive trial, so very good news. Remdesivir given for 10 days, and it had been more than 1,000 patients being randomized, and very good news. So the median recovery time dropped from 15, that was on average with a placebo group, to 11 days in the Remdesivir group. And there was a tendency for mortality to be lower, numerical, not statistically significant. In terms of adverse events, not so much difference. So I think it's the first positive signal that there could be a specific treatment. And those who had been, if you look, it's a nice large trial, and you look into subgroups, but then all you can say is, and those who had been moderately severely affected, those who had been on oxygen but not ventilated, they had the most stable positive response to the drug. Now, systematic reviews, and then we go to evidence-based practice recommendations. Yes, they couldn't be evidence-based at the moment. We are very early, and yet I think it's important to give some practice guidance. And I would like to share from Barbara Wilson, who is a well-known, internationally well-known neuropsychologist, and also the leader of the special interest group Neuropsychology of the World Federation of Neurology, here together with her colleagues from the United Kingdom, from the British Psychological Society. They want to make us aware of the possible neurocognitive problems that occur in people affected by COVID-19. And I think from what I have told you and what we have seen from the previous, in the previous talks, it's clear the brain is affected in various ways. And so it's very likely that a high percentage of these patients who do have encephalopathy or who do have strokes will have cognitive problems. So here our British psychology colleagues, they want to keep our attention, if we look at those people. And I think in other situations, it's similar. It might be neglected. It might not be taken into consideration, not to the extent that these problems will translate in disability and participation restrictions in the long term. But so they ask us, have a look at attention problems, have a look at executive problems like planning, monitoring, action problems, and have a look at memory problems. And if you see that, or if there's a hint, refer people to the specialist. So it's, I think, very important recommendation here. And then finally, I would like to pinpoint to this necessity that we share our knowledge. So we need to generate this evidence that is specifically neurorehabilitation relevant, so that we can guide and achieve the best possible outcomes for our patients. But in this rapidly and dynamic situation, we need high quality at a high speed of publication and open access, so it would be available to everybody everywhere. And here you see the editors for this research topic, as Frontiers is calling it. It's a collaboration of the WFNR with Frontiers. And we have a task force, an international task force of very qualified professionals in neurorehabilitation. I'm very grateful for everybody who joined the group. So we will have high quality peer review, and we will do it very quickly, much quicker than you would usually could have organized. And so we want to ensure quality, and we want to have it done quickly. And one further positive aspect, and that is the contribution of Frontiers. They have a waiver policy for these articles, for this article ebook kind of paper collection, research paper collection. If an abstract had been submitted and positively evaluated, then a manuscript that is going through peer review and will be published free of publication charge. And of course, it's open access, will be available to everybody. So let me summarize what are the topics, really the research agendas we should think about. It's all about neurorehabilitation at the level of body dysfunction. It could be motor, sensory, cognitive, emotional. How does that relate to activities? How does it resolve? What is the evolution of symptoms over time? And what is the pathophysiology of these deficits? It's not just the brain pathology, but the pathophysiology of these deficits, and how responsive are they to our treatment on a pathophysiological level? So is the recovery to the same extent that we know and expect? And if we treat, are our treatments as effective? And there are these questions about use of technology. I think I have very specific questions about the protection of people, staff, visitors, patients. And finally, it would be good if we had more evidence and could come up with evidence-based practice guidelines. So yes, neurorehabilitation is complex. And there is a new diseases, neuro-COVID-19, and we know very little about it. So we have some information already at hand, but then there's a big task for all of us really to invest in neurorehabilitation research and make the results available to everybody. And just to conclude, I would like to mention that the WFNR does have some clinical guidance. It's not really evidence-based, but it's based on clinical reasoning and based on the experience of those like Professor Pistarini and Professor Homberg, who do have experience and know how the system could be run even in COVID times with higher loads of COVID positive and having to take care of COVID negative patients as well. So here are some practical orientations for you. And so far, I would like to end. Thank you very much for your attention. Happy to answer a few questions.
Thank you very much, Professor Plotz. Very nice. I think let's see, what time do we have here? We're supposed to be finishing what, at 9? Is that correct? Wayne?
Yes.
So we still have some time here. Maybe this is a good time. We have 10 or 15 minutes perhaps.
So David, can I make a few announcements?
Yes, please.
Yeah. So Tracy, are you on? Tracy.
Tracy Moe?
Yeah. Tracy, can you talk about the CME credit?
You may not be on.
Okay, I'll just say, can you guys see the World Federation website? Can you see it?
Yes.
Okay. So we got a lot of questions about can they access to presentation slides and video? The answer is yes. So we'll post the video and the slides about a week later. And then you're just looking for education, research, and a webinar. So we'll post this, and we will work with World Federation Rehab and post this this symposium. And then you do have able to obtain a CME, European CME credit, but you need an email. So let me share this. You need to email Tracy and to get a CME credit. Can you guys see this? So if you need a European CME certificate for this event, please contact Tracy Moe at her email. It will be tracymoe@wfnr.co.uk. Okay. I'm going to leave this, and while we address the question, I'll turn to Victoria.
Okay, so we have a lot of questions. We have a couple of people with their hand raised, but we have a number of questions in the Q&A that we're going to try to get to first. We've had a handful of questions asking about fatigue and levels of motivation in patients with COVID and with neurological symptoms, conditions, problems. So if anyone of the panelists wants to kind of field that one as a overall fatigue and motivation.
Perhaps Dr. Pistrini or Dr. Homburg, perhaps?
Well, I think in many of these patients, we have a lot of reasons them to be demotivated, depressed, and it's very difficult to say which of this is based on an organic basis, really, or which is more on the reactive basis, just psychological basis, depending on the, let's say, stressful condition these people are in. We certainly need further research really to sort with that. In any case, what we do, especially in those patients who are isolated for longer periods of time, don't have family contacts and all of this, that we give them a lot of psychological support, both from our clinical as well as the neuropsychologists. I think that is certainly important. It's definitely an issue. We do not know if it's an organic problem or just a reactive problem or a problem within the system of taking care of these patients who very often are in a very stressful condition.
I can reply?
Yes, please.
Rehabilitation for COVID is very important matter now because we have a different settings. Some hospitals have to be adapted their setting to these patients and also to offer rehabilitation to COVID patients for all their needs. Other hospitals didn't accept COVID patients, But the real problem is that in this particular condition, many patients with neurological problems are not so likely to receive appropriate care for their condition. We have to adapt the setting to patients with the COVID condition and neurological decline, and the patients with acute and chronic disease, no COVID patients who never experience the infection. And then we have to reorganize time, intensity, frequency, and setting of our rehabilitation for these patients.
Okay. Victoria, any other questions?
All right.
Thank you.
So we have, we're gonna try and take one from the audience, maybe potentially live folks that have raised their hands. So if we're all willing to give that a try, Niharika Sharma, you've had your hand raised for a while. I'm gonna give you the chance to talk if you have a complicated question that you feel like can't really be captured in the Q&A box. And you should be able to talk now. All right, seems like she might not be ready to answer a question. Let's try one more. Samir Gubug, I apologize if I'm pronouncing that wrong. I'm gonna give you a chance to talk to ask a question. Samir, are you there? Okay. We'll just go with the written questions. Let's go back to that theory. Let's see. Can you give us more information on submitting research papers on neurorehab during COVID-19?
Well, if it relates to this research topic, the research topic, we have the address, how to reach it, the platform on our WFNR website. And so it's a project that is basically running in 2020. And so if you want to submit a manuscript, there are different types of research. I have shown the questions that might be suitable for this research topic, but then there are different types of articles that you would see at the Frontiers website. And the process is to, if you have interest to submit your research, first to submit an abstract. And then the editorial panel will have a look at the abstract and see whether that is fits into the research topic scheme. And then with that, you would receive a waiver for the publication fees before you submit the manuscript proper. So it's these two stages. And the info, you can trace it on the WFNR website.
Okay. Any
And
more?
I apologize. Yeah, there's quite a few. Let's see if we can squeeze in one more. I apologize if I pronounce any of these words incorrectly. Any evidence for ventilation in extubated patients undergone cardiopulmonary rehabilitation?
I have not experienced.
Well, I'm not sure. Our panel is really, maybe Katerina, can you address it? Our panel probably is not very expert in that area, but Katerina perhaps more than anybody.
We definitely know that
Yeah.
patients have cardiological problems. I know a little bit because we have about 100 beds of cardiology rehab. We have COVID-19 positively tested patients with cardiology. I came across one case with a sudden coronary death. We wanted to do an autopsy on them, but unfortunately the relatives did not allow us to do so. There is more and more evidence that there may be primary cardiological problems, especially coronary problems, which may occur in conjunction, not necessarily in conjunction with
I have comment about this. The patients with respiratory function are submitted to rehabilitation treatment for respiratory function, but cardiac problem of a virus are not so clear now. We planned a project to examine the problem of rehabilitation patients, but we have to collect the data to achieve definitive results. We have a good knowledge about respiratory function, but for cardiac problem, we have not definitive results.
Perhaps a couple more questions, but I think we should try to finish on time. Wayne, do you want to stretch us out a little bit, or want to try and finish on time?
We can answer one more question, I guess.
Yeah,
Victoria.
I think that's.
Yeah,
yep.
Victoria.
Okay. For patients having COVID-19 with neurological conditions, is rehabilitation intervention called for in acute phase as in non-COVID patients?
Please.
Read it again.
For patients having COVID-19 with neurological conditions, is rehabilitation intervention called for in acute phase as in non-COVID patients? They might have meant their non-acute phase, though I'm not sure. We can ask another one if that one doesn't really make sense.
No,
Well, the
that's a
answer
reasonable question. That's a good question. I think the question really refers to patients who are acutely ill. Should physiotherapy be involved, rehab be involved when they're in the acute phase of illness? And
Yes.
yes,
If
I think the answer is yes. Mm-hmm.
Permitted to accomplish this rehabilitation. In acute phase, we provide to rehabilitation to patients if clinical condition of patients allow to submit our patient to treatment. But the aim of rehabilitation are short aim, because the time for rehabilitation is short, because the contact between professional and patients is limited, and the patient cannot support for his clinical condition high frequency and intensive treatment. This is the problem in acute phase.
Okay, I think at this point we'll go ahead and stop the webinar. I'd like to thank all of the panelists. I think they had some excellent presentations. I'd like to thank the audience. Excellent questions to the panelists. We can't get to all the questions, obviously. It's a huge audience, and unfortunately, some questions can't be answered. But if you'd like to contact the individual panelists, I'm sure they'd be happy to answer you by email or some other format. But I think that's probably all we can do today. Again, CME credit, check with the website at the WFNR or contact Tracy Mole at the email address that Dr. Feng had given you earlier. I think that's it. This is our first attempt at a webinar at WFNR, and I think it went very well. Thanks again to our colleagues at Duke for their support. Victoria and Will, thank you. And Wayne Feng, thank you. Any other comments, Wayne, that you'd like to make?
Well, I just want to echo with David. Thanks for all the audience enjoying all around the world. And due to that, we are in a different time zone. Some I know are very late, so I appreciate that you stay late with this symposium. Again, you will receive the email about a week later, and we will post on the website. And also stay tuned. We may have a future events like this. So stay tuned with WFNR, and we also have some statement about COVID-19. And so please check our website. So please stay tuned, and we'll see you next time.